Dr. Lorena Vázquez Santiago. I'm right here from Puerto Rico, and we are gonna talk about trauma, resilience, and psychological interventions, especially for Latinx survivors. Why I choose this population is because I'm a Latina. I was born in New York, raised in Puerto Rico, and I personally work with a lot of individuals who were or who has been exposed to any type of different trauma, domestic violence, and also sexual abuse. We are during the presentation, we're gonna talk more about the Latinx survivors and especially the mental health services, trauma, resilience, and psychological interventions. During the training for us when we go to school to become psychologists, we learn the basic tools required to assist others. However, depending on the different clinical skills, they are not necessarily the only resource that we need. Recognizing the trauma, resilience, and the psychological interventions, it is important and more so understanding the cultural baggage that that person brings into treatment. Why I place so much importance into the cultural aspect of it is because if we think about the different communities, especially the Latino population, depending from where we are at, they may or may not be able to speak the same language. They may or not be able to have access to the same resources. For example, one of the important parts when we were talking about the different rape kits in the presentation before, one of the things that always blows me away is how we need more assistance, at least here in Puerto Rico, like Dr. Angels was mentioning, is a backlog of the different rape kits. So that's also making it more difficult to go to the judicial system. But understanding where this person comes from when they are able or they are not able to report what other things are involved, the cultural aspects plays a big role in it too. So for today, we are gonna have the objectives of identification, the main components of trauma in the Latinx survivors, also classify the different responses based on the resilience with Latinx survivors, and integrate psychological interventions to assist the Latinx survivors. Very important, even when this presentation has the goal to portray the Latinx population, many of these clinical considerations can be used with other cultures. My main focus, like I mentioned before, is with the Latinx population because that's the main population that I work. I used to work in Arizona. I also I have practice here in Puerto Rico, and that's the main population that I work with. The specific difference that I'm using the comparison are that's my main population that I personally encounter as a practitioner and as an educator. I'm also a clinical forensic psychology, and I teach in the graduate school for counseling. When we talk about the diversity aspects, we have a basic understanding of the culture, and that is important, but the assessment of that culture, how that person is able to recognize what things are more close to me. When we are completing an assessment or evaluation, we need to take into account the specific differences of that individual. And that, to me, that should be the #1 priority. Let's take an example. If we compare different family members, even when we have a family and we have, let's say we have a set of twins, they have many similarities. They may share their birth. They may share the same elementary school, middle school, high school, but even when they have all those experiences, they are gonna have individual traits and individual belief system depending from how they are interacting with each other. So the life events are not necessarily going to be seen the same way. In the Latino survivors and mental health, we also work with the different survivors in especially to be able to understand what mental health means. When I go to a psychologist or when I go to a mental health professional, what does that mean? Do I need help because I'm struggling with something in my life? But how is the cultural aspect of it? What is the pressure that it's being placed, and what does that mean? One of the biggest challenges that I have seen recently, and it has been shifting. Before, whenever we hear any mental health, the first thing that it pops up into mind, we quote unquote think about the word crazy. And then people freaked out and say like, what? I need what? I need to go to a psychologist. I need to go to a psychiatrist. What does that mean? Well, we are looking more and trying to shift that mentality and seeing, well, we need specialized treatment. We need to help others. And especially if I'm in any need, I'm able to get that need met. For us, when we are working with a client, I always try to teach my students and anybody that is near me that we need to connect with that person. Yes, we do know we have a bunch of theories when we are talking about the theoretical interventions or all the different school of thoughts. But what is the number one priority? The number one priority is that person that is in front of us. How we are going to connect with that individual, depending from what we say and how that person can engage into treatment, it can make the difference for that individual. So that the most important part is to begin that therapeutic intervention by connecting, but not as in a superficial level. We need a connection in a deeper level with that human being. Also, to understand, we have to ask many questions, and all of these questions are important. For example, when we think about Latinx survivors, where are they from? I mean, we feel or we try to fit into a category, Latino or Latinx, but where are you from? Are you from Puerto Rico? Are you from Dominican Republic? Are you from Mexico? Where are you living at the moment? Because it's not the same, even though we are all Latinx or Latinos, but we are living in different parts of the country or in our own, back in our home. So that's going to have a different aspect because of the resources that we are able to receive, especially when we are engaging with our survivors, what they are sharing with us. Many of the clients, as soon as they start the therapeutic process, they don't necessarily come into therapy to tell us the story. Hey, I'm a survivor, or hey, I had this happen to me. And one of the important parts, what I try to make sure they feel that they can connect, that they are in a safe place, and they are able to share that information. It's one of the biggest parts. It's how we are sitting with the silent. For example, if you have a survivor and you are trying to engage with them and they just start talking about what happened to them, but then at any given point, they are not willing to share any more information. Well, that's maybe because it's a very difficult question for them. Let's allow them that space. Let's give them more time to be able to connect or reconnect with them. The cultural perspective, to me, that's one of the biggest parts, because when we talk about cultural differences, it's not necessarily if I'm only Latina or if I'm from Puerto Rico or if my first language is Spanish. It also has an impact depending from where I'm working at. If I'm at the prison, for example, what does that mean for them to share that information knowing that I'm a female, knowing that I have a male provider? So what is that? That has to do with how we are gonna encounter the mental health services. What is the family pressure? Who is the alleged perpetrator? Is within their family members? Most likely, depending, like the last statistics from the RAIN Institute, at least the 80% of the perpetrators are known to that survivors. So what does that mean? It's somebody that they trust, and that trust has been taken away after an event. It's very important to understand in the Latinx community the gender roles. Are they traditional? Are we having a lot of machismo in that family or in that individual? What does that mean for treatment? Is that person able to go to treatment, or even their family are telling them, you know what, you don't need any services? I had an intervention not too long ago that the father figure was mentioning to the survivor, no, you don't need any treatment. And because it was an adolescent, it goes to the legal component, and it also, we need more education and psychoeducation to that parent, but it's not an easy task. So one of the main parts, as more as we can get out there and as more as we can share with the individuals the importance of treatment, the more normalized experience they are gonna have. And like one of the first things that I started was the resources. What kind of providers do we have? Do we have providers that are able to speak the same language of that individual? For example, I started mentioning that I used to live in Arizona, and that's when I went to school in California. My first language is Spanish, but even though my first language is Spanish, when I was with my colleagues, my classmates who were Spanish speakers, they are not necessarily talking exactly the same language. And simple words, and I'm gonna make an example. For one of the biggest examples that I use when I'm talking about sexual abuse or trauma is the word coger. Coger in Spanish is to take. But for me, as a Puerto Rican, coger means like take from. But then if we are talking with a Mexican person, they are gonna mention or they are gonna associate that word with have sex. So it can be simple, but it also can complicate the relationship and building that relationship with somebody who was just in a sexual abuse case. If I went over there and say, hey, let's just take a break, hello, what's gonna trigger for them? The access to care. Are they able to have, like they were mentioning in the previous panel? Sorry about that. I think I hit mute in here. So the access to care, are they able to have specialized treatment? During those treatment, do we have any language barrier? Do we need interpreters? Or is anything else that it's making more challenge that relationship? Trauma in the DSM-5 can be defined as the exposure or to actual or threatened death, serious injury, or sexual violation. That's why it's connected the Latinx, the mental health, and the trauma part, because in this case, we are looking into the different sexual abuse survivors. It can have or it can be manifested with an intense fear, horror, or helplessness when it predominates. And when we are thinking about the trauma, there are different variables that we need to look into. For example, if somebody was referred to us, depending from where we are working at, it's any child sexual abuse. Who was the perpetrator? Is the perpetrator male and the survivor is male? Is the perpetrator female? Or the survivor is female or male? Why I choose to bring this up is because depending from the chronological age, a lot of people in the Latinx community normalize that to have sexual encounters or sexual relationships with younger people. And we were talking with the age of consent. Here in Puerto Rico, the age of consent is 16 years old. But what does that mean with somebody that is older than 16 years old? Well, it's gonna depend who is or how old is the other person. And then we move into the child category to the adult category when we have a adult as a sexual abused. Who was the perpetrator? It was a male perpetrator or it was a female perpetrator? Well, sometimes we have to even go into communities and educate individuals because they think, well, if it's a female, no, she didn't rape me. Oh no, that cannot happen. Females cannot sexually abuse any male. And that's the mentality out of it because of the machismo and how the cultural aspect can play a role into it. Also, we have another category, which is individuals with disabilities. Is this person cognitively impaired? Is this person have any other disabilities that plays into role? Then again, I always try to ask when I'm doing the assessment, who is the perpetrator? Is female, is male, is depending from the different categories. Why this is important is because depending from who is the perpetrator, they can normalize that, or they can report on the report what happened to them. Very important, how we open up the conversations of child sexual abuse. When we are working with sexually abused survivors, it's very important how we are managing our nonverbal, what we are telling them in the language, but also our facial expression, our body movements. It's very important to explore about what happened after those reports or those allegations of sexual abuse. Is any family support? One of my recent cases, I have this young female who mentioned that as soon as she reported or revealed her sexual abuse, the first thing that the mother mentioned is that no, oh no, that never happened in here. Oh no, you cannot tell, you cannot talk about that. Whatever happens in the house stays in the house. And those cases are when we have the family allegations. Is any siblings involvement? What we are gonna do, how we are gonna address this? We are gonna work with the family reunification, or is anything else that we need to address? And we bring the resilience to the process, and the American Psychological Association defines the resilience, the process of adapting well in the face of any adversity, trauma, tragedy, threats, or when it has a significant sources of stress, the family relationship problems, serious health problems, workplace stressors, or financial stressors. And then how we fit the resilience into the sexual abuse, while shifting that mentality, depending from that experience, and empower that client, that person, that individual. And that's when we can connect the empowerment and build up the survivor's leadership. Empowerment starts even with the language that we use. I love when Paul was mentioning, when he started talking about, and he got himself talking about violence, and then like how he shifted to the survivor. That's actually how we can continue doing this work and help others into the community. In the psychological interventions, one of the priorities is to understand that the cultural baggage of our individuals help us to create a better view of their life experiences. As a psychologist in the academia, we focus on to teach and to learn about how important is diversity. However, it's very different that the things that we learn and the things that we can experience in our own skin. How is that affects treatment? Is that person comfortable into going to treatment, or what are the fears that they are having, and normalizing their experience? Why? because it's important. If you want to help an individual, it starts with whatever their needs are. And we can have an impact on the treatment outcome if we know or we learn more, we take the time to understand where this person is coming from, what are those needs, and how can we assist them. Very important. When we think about the psychological intervention and the psychological services, what type of services are being offered? Is they need to the means to pay for the psychological services? Are they any sliding scale fee, or they are community resources? One of the important parts, how long this person needs to wait for services. And I bring this up because, for example, here in Puerto Rico, if somebody needs psychological treatment, it's gonna depend on the first thing that they look is to what type of insurance do you have? Or are you able to pay out of pocket? Just to make an example of that, for me to be able to find some resources for psychiatrists, my clients can wait anytime from 3 months to 6 months to see their psychiatrist. And how often they are able to see them? Well, that's gonna depend, like I mentioned, the insurance, or if they have the capacity to pay out of pocket. And to me, that is not necessarily a service. That can be a disservice. For us as therapists, we need to understand what are the dynamics of complex trauma, trying to understand what is the dynamic of sexual violence, how is the child sexual abuse impacts, not necessarily when it happened, but through the entire life. And what is that the diversity component that it's played and how it's been played. Very important for everybody just to have an environment that they can feel free of judgment, and they can feel free to say and safe to say whatever they need to mention, however they need to disclose that information. To me, that's not negotiable. And then we need to address the therapeutic toolbox by normalizing the experience and assist them with the symptom management, including their sensations, flashbacks, if it includes any panic attacks, nightmares, disassociation, negative thoughts, fragmented memories, shame, guilt, and always assess for suicidality or self-harming behaviors. Inside of the psychological interventions, we need to look into the crisis intervention. Just when it happens, as soon as somebody discloses what happened, to have somebody else in there available. Individual intervention, just to target how is that impact. Also offer couples intervention. What does that mean after an assault? What it's gonna happen, or what are the couple's needs at the time, and also the family interventions. Why I bring this up? Because it's very important to include everybody in that one. Once is any sexual event that occur, all the family members get impacted in their own way. They can express them or they can shut down, but it's important for them to have a safe place to be able to vent and to talk about it. And I listed in here a couple of the references and my contact information. You guys have any questions?
Do you mind putting your contact information in the chat as well? And that way people can copy and drop that in.
Absolutely.
Thank you. Thanks so much. Thanks to Dr. Vázquez Santiago, and also the genius scheduling of